our trust board meeting in public, which during social distancing restrictions means that this is a meeting we are recording and will make available for the public to see via our YouTube channel. We also have in the meeting three of our governors: Anita, whom you've just heard from, Gemma, who some of you saw arriving, and we should have Cecilia, but I haven't spotted whether she's joined us yet. But we are, I think, expecting Cecilia as well. Neil, is that right?
So correct, I don't think she's joined us yet.
Okay, so welcome to you. It's in one sense you don't see anything different than would be seen by all members of the public and fellow governors in the YouTube. In another sense, you do get a different sense of the way in which the meetings operate if you're able to be there, and it's very important that our governors are able to see the workings of the board and in particular understand the contributions that non-executive directors are making to the discussions, and that's why we've made sure that even though we're meeting virtually, we have some of the governors able to actually sit in and not just watch it. We will need to continue these meetings virtually while the COVID visiting restrictions are in place, and we're keeping that under review, as indeed are many of our trusts. And when we get to the Chief Executive's report, which today is presented by Meghana, because Meghana is being the Chief Executive while Bruno Holthoff is on leave. That means that we also have with us Dr. Elaine Hill, who's the Director of Medical Workforce, but is stepping in for Meghana, so that we do have the professional complements around the table that we need. So welcome to Elaine. Elaine, if you want to say something and wave, and then you'll pop up on the screens, and governors may not have met you particularly. So,
okay. So good morning. I'm Elaine Hill, acting as CMO today and also Director of Medical Workforce. Good morning, everyone.
Thank you. And it being holiday time, we have, I think, a number of apologies from some non-executive colleagues. So unless they've come in from holiday, I don't think we have Tony or Gavin. So I think that's right, isn't it, Neil?
Yes, that's correct, Chair.
Although we have, I think, feedback in from both of them in different ways, because some issues have come through the combination of discussions with the university, and we will have later on the evaluation of the CQC maternity visit, and Tony is our maternity champion and saw that draft as it came in and helpfully fed in some observations in terms of how we understood that. If I'm indisciplined in my chairing, I think we may lose Joy briefly at about 11:30, because I think she has another commitment, but maybe we can be so efficient and focused on our business that that won't matter. We'll be joined for the item 13 by Susan Paluca, who I think will be known to everybody because of the work that she's done recently on the Constitution and for other work earlier when she was working with the Trust. I think those are the housekeeping issues. Neil and Laura, unless I have missed anything. Meghana.
Chair, our Director of Infection Prevention and Control, Katie Jeffrey, will join us for the annual report for IPC.
Thank you very much for finding that, Meghana. And we also have an item on the agenda in relation to the use of lateral flow rather than PCR testings, and it might well be very helpful to have Katie's support available, given that infection control is her area of expertise. So we might perhaps invite her to be there for that item as well, Meghana, in case any questions are raised. Great, thank you. That takes me to declarations of interest. Unusually, Neil, I have one I should say, which I have accepted an invitation to be a visiting professor in bioethics governance at the University of Oxford, which came through in June. So I should add that to my declaration of the of interests. Laura's just put in the chat that Susan is already with us, which of course she's fully entitled to. It's a public meeting. We're delighted to have you, Susan. Are there any other new declarations of interest that we need to record? There are the usual declarations of interest, Anne, and I think you probably just want to remind Neil to go on the record, but Laura is taking notes today, so she won't be familiar, but so perhaps you should actually say them this time, Anne.
Okay, so my declaration of interest is as a trustee of Oxford Hospitals Charity, and I chair the audit committee.
Thank you. Are there any other declarations of interest that we need to put on the record? Okay, thank you very much. May I then take us to the minutes of our July meeting? I'm alerted that there's a minor error on paragraph 46. Neil, can you remind me what that is? No, it's the quick answer by look at it.
Sorry, I struggled to come off mute there. So I'm just reminding myself it was. Yes, the word competing should be completing.
Okay, that makes sense. People's competing appraisals. So thank you. Are there any other errors that need correcting or? Okay, thank you very much. I don't think we have formal action log or matter arising issues that are there, but people will remember that we heard a staff story last time, which raised lots of questions in our minds about the experience of some groups of our staff. And I know, Terry, that significant follow-up has happened from that. Now, some of that, of course, relates to the individuals concerned, and you won't be able to talk about in the public section. But it would be very helpful, I think, to understand the sorts of steps that followed from the staff story last time and the work that you and colleagues have done to follow up. So, Terry, I'll give you a chance to comment on that.
Thanks, Jonathan. So you may or may not remember that there were kind of like 3 categories of action in relation to the staff story that we highlighted. Those that were actions that were to support the individual, also actions that were related to her case, and then actions that we needed to take in relation as an organisation. In relation to actions to support the individual, all of those have been taken. The protection has been enacted. Sam, the chief nurse, and I have met with the individual to look at all of the career options, and there's a favourable outcome in relation to that. Also, there has been positive engagement via the BAME's staff network. They've also highlighted to us and wider to the individual, although not individually to the individual, about how happy they were that the steps were taken, that it was raised, and also there's also feedback how they were happy with how seriously the board took it, and also the fact that the chair of the board, yourself, Jonathan, also apologised on behalf of the organisation. We've also ensured that the individual has had psychological support as well. In relation to the action around her case, essentially the chief nurse and I have met with the individual, and they've indicated which route they wish to follow. And finally, in relation to improvements as an organisation, some of that you'll see in the combined equality standards report, which has been addressed and discussed today. And we're also continuing to work with the BAME network to co-create solutions. And we're also looking at anti-racism training and how we embed EDI in all of our management and leadership training.
Thank you very much, Terry. What I'd like to propose is that we note that there's been a response to the individual issues that are raised, and that we pick up the wider organisational questions as we get to item 10 on the Equality Standards report. I imagine, Terry, that like many of us, the fact that we took that staff story is flushed out other things that have been raised, and that people are coming forward with things that may or may not require particular scrutiny, but I'm hopeful that the fact that we've shown that we do want to address these things is making people feel more able to raise them. And that's certainly been my sense from talking to people, that they are raising other things, which no doubt in the short term creates extra work for people, but it will help us get an organisation get to a better place. Is that your experience as well?
Yeah, I've received a large number of emails, some supporting, some not necessarily supporting, and also a large number of requests to meet with individuals as well. And part of the way forward is how we make sure that there are supportive structures so that they can be dealt with at the level at which they've been brought up, rather than having to be escalated to the chief people officer.
Thank you. I mean, I think I would just want the board to note that if we get a significant number of things coming out that people want to raise and discuss with us, that's actually a sign of success. It doesn't tell us that everything is worse than it was previously. It does tell us that we can get to grips with things. So we should expect, I think, as people believe we're taking this agenda more seriously, that it appears that problems increase, because that's the only way we can get to the bottom of them. And in the same way as it's healthy to have a significant level of complaints because it enables you to learn about what goes right and wrong, we must be careful to respond appropriately to these things. And I think what Terry's described is, when people bring them up, we get them into the right systems and the right procedures so that they can be resolved. And let's pick up the broader issues when we get to item 10, Terry, if you're happy with that. Are people happy with that division of labour in the meeting today? Okay, thank you. Are there any other matters arising from our previous meeting that aren't on the agenda that Neil and I have missed? Okay, thank you very much. Next item is Chair's business. I think like to mention two things. There's three things. The first one is thank you very much to Anne for holding the fort while I've been away on leave. I much appreciate that. The second is that we obviously have a significant interest in the integrated care system working smoothly, and my understanding is that the appointment process for chairs has worked its way through over the last couple of weeks, and we should quite soon have announcements about chairs on the ICSs. In the South East region where we sit, only one of the existing chairs has been appointed without a recruitment process, and that's in Hampshire and the Isle of Wight. All the other ICS chairs have gone into a competitive process. My understanding is that that is likely to include current chairs in that process, so it's not an indication that there won't be a continuity, but I hope we will know probably in the next couple of weeks who the chair is for the ICS, and that will then enable the appointment of the chief executive or accountable officer for the ICS, and those two appointments hopefully will enable the ICS to increase the pace of its work in preparation for what we still expect to be the statutory creation of ICSs next year. As soon as we know the outcome of that appointment process, it's been made public, we'll obviously brief people, but I think that will be before we meet again. So I'll let people know as soon as we hear. And the third item is just to remind people that we are not discussing the Freedom to Speak Up review today because it's scheduled to come to the October board meeting after it's been reviewed by the Trust Management Executive later this month. But many of you have been involved in what I think have been very productive and interesting sessions with a very wide range of staff about their views on what goes well and what they would like to see differently, and some of the opportunities and challenges as we review how we take Freedom to Speak Up forward. So I take the opportunity, because Susan Paluca's already in the meeting, to thank her for the support she's given to that process, and I think colleagues will have found it quite illuminating, the degree of candid comment that people have been prepared to make, which I'm very encouraged by, because there've been some positive and some negative experience aired with us, and execs and NEDs have been able to hear that firsthand in those processes, so that when it comes to us a set of proposals, I think we'll have quite a good sense of the opportunities that are there. So that's just really to remind people that's why we haven't got it in substance today, and to thank everybody for the work that's gone through. So I think those are all the items of Chair's business, unless, Anne, anything came up while I was away that should be in the Chair's business that isn't. Great. In which case, can I hand over to Meghna as Chief Executive to speak to the regular Chief Executive's report. Meghna.
Thank you, Jonathan. So first of all, I'd like to just begin by saying thank you to all my non-clinical and clinical colleagues for the tremendous work that they've put in over the last few months and almost 2 years, and commitment to continue to do so. And I hope that most, if not all, have had a summer break that has allowed them to rest and recover. So starting with COVID, we have circa 40 to 50 patients in the hospital over the last 2 weeks each day, with a split of around 30 to 35 in the John Radcliffe and 7 to 10 at the Horton. We have had patients in the intensive care unit in the last week, but currently, as of yesterday, we had 1 patient who was mechanically ventilated in the intensive care unit. Of course, what it means is if the intensive care unit is occupied by COVID patients, we have to eat into the capacity for intensive care for elective green patients. But safe to say that we have a CITREP that is formulated every morning, which tells us, and the intensive care teams are working together to make sure that the resource that's available is utilized in the most appropriate way on a daily basis. So that is good. Few really good pieces of news in the CEO report. So the Oxford Vaccine Group and the Jenner Institute won the Excellence in Healthcare Award in July, obviously for the reasons which are well known to everybody, which is fantastic position to be in. We also had our CQC report into infection prevention and control released in July following a visit in May. And the Chief Executive, Bruno Holthoff, did send a personal message to all staff after the CQC report was published, thanking them for their approach. The CQC highlighted many positive areas, and in particular, the skills and abilities of the IPC, infection prevention control teams, and made a positive note that the leaders operate effective IPC governance processes and the trusts have an open culture so that patients and staff can raise concerns about infection control without fear. There were some minor improvements to make, and I'm pleased to say that the teams have already acted on those. In case during COVID, another bit of news is that we continued to perform kidney transplants, and we have actually performed more kidney transplants in 2021 than in 1920, which is a tremendous achievement. Obviously, all these transplants go through the Churchill Hospital, which we have tried to keep green as far as possible. We also have good news for our tiny patients from neonatal and pediatric intensive care, where we have new modern ambulance services for them between us and Southampton, University Hospital Southampton. And these are really good new ambulances. This was a risk which we had for a few years, and I'm thankful for Jason and his team to working with our clinical teams in achieving this excellent news about new ambulances. We also have ANPR now finally in place, which I know Bruno would have been very pleased to report. So this is for our staff, for our visitor car parks at the Churchill and the John Radcliffe, which will be very, very handy for everybody who is in those car parks. The last bit of news really is that our BRC application, which is the application for the 4th round, has successfully gone through stage 1. And we're now preparing for the stage 2 application. All our 15 themes went through, which is fantastic achievement. And the committee noted that we have a very strong application. but also noted that we have a large number of themes, so have 15 themes across a broad range of areas. And really what we will now work with the BRC steering committee is to really show that golden thread that flows between all these themes to achieve the combined aims of the NHS and the university, to be able to detail the governance and oversight of these themes across the partnership. So that's what we'll be focusing on now. Just to note that we had 20 themes in the previous BRC round. We're now 15, and actually the other BRCs have a similar number of themes too. So we feel very positive about our application, which will be going forward to stage 2 in October. And the very last thing to update the board about is you would have read in the news about the shortage of blood tubes. And we nationally and regionally and locally, we have worked very well and made sure that the supply chain has held together in terms of supply to primary and secondary care. And we have sent messages to clinical teams about reducing unnecessary blood tests. And we have achieved a little drop in demand, but actually we haven't. The more important thing to say is that we haven't run out, and that has been managed well by teams. And finally, the last bit is about visiting. So and the other requirements on NHS sites, particularly ours. So we continue to maintain social distancing on all our sites, along with use of face masks and the other measures such as Clinell wipes and hand washing. The visiting rules remain the same, which is the rule of 1. However, of course, there are exceptions for patients who are at the end of their life, so end-of-life care patients, and also for maternity, of course, where partners are allowed for scans and birth and postnatal visits. So I'll stop there, and I'm happy to take questions.
Thanks very much, Megan. We need to remember how high the prevalence of the virus still is in the community, and obviously, while the community is relatively safe compared to the previous wave, and the hospital admissions are fewer, the people we look after in hospital are those vulnerable ones, and we have to be really careful to continue to protect them. Hence, we're not having this meeting on site and running the risk of people coming in. Are there any questions, comments, observations for Megan on the Chief Executive's report? Thank you very much. That then takes us to this month's patient perspective, and I'll hand over to Sam.
Thank you, Chair. So this month's patient story is to share with the board some insight into the Trust Fetal and Maternal Medicine Service, how it supports women, babies and their families, and to share stories of 2 families who've been supported by this service and also some staff experiences. So just a little bit of background, the Oxford Fetal and Maternal Medicine Unit is an multidisciplinary team of professionals, and they're based at the John Radcliffe site. They provide diagnosis, counselling and treatment to patients across Berkshire, Buckinghamshire and Oxfordshire, also Northamptonshire and Wiltshire. For some conditions of these ladies, advice is offered so that the pregnancy and the birth can be managed closer to home. And for more complex conditions, diagnosis and treatment, the birth is led by the team at the John Radcliffe Hospital. So this is a team that's well known in the Trust. Megan knows this team really well. I think we could probably all guess the clinician that was mentioned in the story, and they have a really, really huge reputation for caring very much about their patients, and they really compassionately and holistically look after this group of patients. The service supports our most high-risk mums and babies, and the team are continuously learning how to balance risk, deliver holistic care to those families with compassion, give information to enable pregnancy to be supported and enjoyed as far as possible. The team are under increased demand at the moment, so we'll be working with that service to understand this and plan accordingly. And just to finish this before we open to questions in the background, I'm hoping David will just flash up a picture for me. My technical skills are lacking as usual. Catriona, who's one of the ladies mentioned in the story, sent through a picture of her baby yesterday that she asked us to share. And if David is able to screen share, it just always really, picture tells 1,000 words, doesn't it? And it always really brings things to life. So I don't know whether David's able to share that picture. If not, we can share it. But she asked for that pic to be shared, just to show the joy that her baby's brought with the support of this team.
I will share it now, Sam. It's always a test for the digital officer.
Sorry, it's got to be you, David, hasn't it? There we go. So the patient experience team have been in contact with patients who kindly supported us with these stories, and she shared the pic yesterday so that we can just see the reality of the outcome of being cared for as a high-risk mum, and how lovely her baby's looking now and thriving well.
Thank you very much. It's particularly nice to see what happens when things go well, despite the fact this is a group of people for whom it might not have gone well. Questions, comments, observations on the story? I can feel an emotional response, but that's because we had our first child in June. So, you know, baby pictures elicit a particular response to me at the moment.
I know.
So. Can you say something, Sam, about the nature of the groups that are vulnerable? So, you know, we've heard a lot about the normalisation of care for people for whom these things might be quite difficult, and we've a number of times asked what we know about the experience of people from ethnic minority groups who may be more vulnerable. We know that there are national indicators that they can often have greater risks. Can you give us a sort of flavour of whether that is an element of this service? Does it deal with more women from those groups than the main service does?
So I can ask Meghana to join me for any comments as well. I mean, patients who are, you know, from deprived areas, socioeconomic deprivation, are at higher risk of some of these medical conditions. So by default, that will include the group of patients that the board will remember. We talked about the Lotus team not very long ago, which is a team looking after vulnerable women from Black and ethnic minority backgrounds, victims of domestic violence, and other vulnerable ladies. This is particularly focused on the medical conditions of mums and the wider sort of complications that come about from them being pregnant. So let me bring in Meghana if she can just add anything there.
Thanks, Sam. So yes, I mean, I have to say that I worked in this unit with these individuals, and they deliver a fantastic service. The outcomes are superb. There is no question about it. And actually, the referrals come in from not just the southeast of England, but a much wider area across England and outside of England. In terms of vulnerabilities, Sam is right. The demographic changes demographics do mean that certain obstetric conditions and certain fetal conditions happen more commonly in these communities, and there is every facility for such patients to be managed and treated in the fetal and maternal medicine unit in Oxford.
Thanks, Meghana. Got a little queue now. That's given a chance. So Jason and then Paul after Jason.
Thank you, Chair. I was just going to comment that something that sort of is sort of obliquely referenced in the paper, but I think doesn't come to the fore, is I think this team really should be applauded also, not just for the sort of the high quality of care they give, but actually for how innovative they are and the innovations they help support. So just a couple of things in the paper. I mean, board members, there's a reference to pre-eclampsia, and many board members might not know that we were one of the centres that piloted, trialled and evaluated the placental growth factor test, which is now being rolled out nationally in the NHS as one of the markers for pre-eclampsia, and we were, you know, absolutely the front of actually evaluating and rolling that out. And we've done some really award-winning stuff with technology on gestational diabetes pathways. So I only mention that because we sometimes grapple with how to combine how to get the benefits of actually being a tertiary centre through to our routine care of patients. And this is one of the teams which both does that for the patients they serve, but actually some of the innovations that they have either introduced or helped introduce are being pushed out nationally and regionally as a result of their work, which is, you know, just an extra angle on actually the good stories in this paper.
Thank you, Jason. Paula.
So Jason may have given me quite a good segue there, I think. It's both heartwarming, the story, but also important, very reflective when you read about the bits and the worries that happened when things weren't perfect all the way through, and I can completely understand that. It says in the papers about next steps and some ideas led by Sam. I just wonder if you could give us a bit of colour on what that meant. It's in the recommendation at the end on page 18.
I think I did mention. I think there's a number of different services, and what I didn't mention is the afterthought service, which when we do get numerous concerns and complaints and reflections of how things didn't go to plan across the board for patients of all pathways. So I think that what the service is doing at the moment is looking, as I say, there's some overlap with the Lotus team, there's the Silver Star team, there's the afterbirth service. So what we're looking at is the totality of our capability and capacity and skill set against demand, so that we can come up with a clinical strategy that will work with the divisional team and the executive to think through. There's also a lot of charity support with the Silver Star charity. So I think we just need to bring that together, just take a step back and look at sort of capacity and demand and the skills that we have and how we can just review some of our pathways.
Thank you.
Thanks, Sam. And I think this relates to a conversation we've been having about the board sightline on maternity, that we have lots of different reports in slightly different formats because of things we need to monitor, and it doesn't make it as easy as the board would like to have it to see the totality. And I know you and the team are working on how we might pick that up, and I think that point just illustrates the fact that we see bits of it, and it's quite hard for us to get a sense of what that adds up to as women's experience. Thank you. I've got Anne, and it'll be Claire after Anne.
Okay, thank you. So I hope my building work doesn't come to start again when I'm speaking. You possibly covered it. I was going to specifically pick up on it's paragraph 9 just before the conclusion, which is the staff experience, where they do refer to overbooked clinics and long waits sometimes. So I was just going to sort of home in specifically on that point to see whether we had plans at this point to try to address that issue.
I think this goes back to Meghana's point that this service has a national reputation. We're victims of our own success, and not unique to this service, but the acceptance of referrals from much wider than originally planned is where we find ourselves. That's difficult to turn off, I think. Relationships have been built. So, as I say, I think we need to just step back, look at current service provision demand and where that's coming from, and then plan accordingly. And that may mean diverting them out of area to other services, but I think it's always very difficult when services have a national reputation.
Thank you. Claire, and then it'll be Eileen.
Thanks, Jonathan. One of the things that struck me very much from the patient stories was the sort of different quality of interaction with clinicians in their description and how important that was to their overall experience. And I just wondered if you could comment on sort of how we use that sort of feedback, and also how we use training with clinicians just to sort of help them understand the impact it might have on individuals.
So I think Meghana can join as well. I think there are a variety of different mechanisms. I mean, what's great for me, I'm desperately writing notes because the team are really keen this morning to hear the board feedback. So this is a story that's been shared with, these are stories that have been shared with the team. They're very keen for board feedback. As I said in my introduction, the team are constantly trying to learn and understand. There's regular feedback around themes from complaints. All complaints are investigated with individuals so that they can reflect. More serious concerns are escalated via the professional lines and into appraisals, but more generic learning is embedded through standard sort of training and induction. I think the CQC report did really sort of reflect some improvements on learning. I think on our last CQC inspection, even though there were posters on walls around learning from incidents and complaints, even in the rooms that staff were being interviewed in, staff found it difficult to articulate practice changes from learning. However, as we roll forward a couple of years, I think the CQC have given us assurance that that learning environment has really strengthened.
If I may come in, Jonathan, I just wanted to say that so compassion and empathy are at the core of every clinician, and I think it comes more to the fore in maternity services. And these being an obstetrician myself, I can tell you that these moments can be extremely stressful at times. And actually, yes, it's 99.9% of the times a very happy story, but nevertheless, one has to be prepared and trained to be able to deal with those 0.1% of times when we have to deliver bad news, and we have to really talk through complex decision making with families. And the Royal College of Obstetricians and Gynecologists is aware of this, has focused on this as part of training, and there is multidisciplinary training for all staff in maternity to enable such conversations and support. But as with everything else, it has to be a scene of continuous improvement, and these are things that have to be applied on a daily basis with reflection through such case stories as we have here today, and also the Maternity Voices Partnership and the local maternity system where these discussions are had regularly.
Thanks, Meghana. Eileen.
Thank you, Chair. I would support and echo all the reflections that colleagues have made so far. And my comment was really more so a reflection on the selection of this for the patient perspective today, and really to congratulate Sam and the team for pulling it together, because I think there is an old adage that says that when somebody receives good service, they tell one person, and when they receive poor service, they tell 10. And I think that there can be a tendency for us in our drive to continuously learn to often focus on what hasn't gone so well. So I think at a time when staff are perhaps tired, feeling the effects of the delivery through the pandemic, etc., that this is really positive, and I felt very uplifted to read it in preparation for the board and reading the papers, and to remind myself of the complexity and the spectrum of services that we give from your regular delivery, which brings great joy to people, right through to these really stressful, complex deliveries and the support for women through their pregnancy on it. And it made me feel very proud, actually, of the things, notwithstanding the opportunities for learning always exist, and notwithstanding the fact that our CQC report, as we receive later, helps us identify not just good practice, but more opportunities. But I just want to say, for me personally, I found it a very good story to read, and it reminded me of the reason why we all come to work every day.
Thanks, Eileen. Joy, your hand was up and it's disappeared again.
Well, sorry, I didn't want to. Well, I was just going to say, as a new member of the board, I enjoyed reading the stories, and but I didn't want to kind of prolong it, because I think Eileen also said quite a lot of what I was going to say. So it was good to see not only the good stuff, but the stuff that was not as negative, and the learning from that. I did have a question about there was something I read about older mothers, and actually the percentage of people that we will treat are going to be slightly older, and I wondered about that. And I don't know, I was just thinking, how do we support and how is the service preparing itself given that particular demographic?
That's an interesting question. We might have to come back to you, because I was thinking, in the Dr. Foster report, there is a reflection that the population is getting older. So I'm not sure we do anything specific for older, what's deemed older, Joy. So I might just need to come back to you on that one, unless Meghana has.
No, that's fine. I couldn't remember where I read it, actually, because there were so many papers. Yeah. I was like, I was just reading it all. But yeah, yes, I wondered if there was anything we needed to do in particular about it. But the age has gone up anyway, hasn't it?
Yeah.
In terms of child birth. So yeah,
I'm pretty sure it's in the Dr. Foster. As the meeting goes on, I'll reflect and have a look. But I think our patients are all they have, as you can see from the documentation, such significant increase in risk assessments around a whole variety of areas. So whilst we've got improvements to make around documentation, the aim is to treat all women as individuals and apply the appropriate risk assessments, and then their management plan will flow from there.
Thanks, Sam.
To come in on that, Meghana.
Yeah, I just wanted to say, Joy, that actually it is well known and documented and evidence that with increasing maternal age, the risk of certain conditions for maternal and fetus rise. And whilst this was relatively uncommon, it is obviously increasing, as you note. So individual risk assessments are important, but they need to flow through into decision making. And of course, Montgomery decision in terms of consent is even more important, given the point you've highlighted.
Thanks, Megan. No relation, the Montgomery decision.
Neither is Dr. Foster to me, although I am married to a Dr. Foster.
They get to Gloucester.
Thank you.
So I think, Joy, one of the things that in my mind we don't have a very easy sight on is the difference between our, if you like, our local mothers, where you would think that we would track the sort of national pictures about the implications of higher age and those sorts of things, and the sort of service we're hearing about here, where our catchment is going to be much broader. So I think we one of the challenges is getting a good sightline on the board is being able to disentangle those women who are coming through with particular needs, where we need to understand how we tailor our services to them, and those women who are coming through because they live locally. And that's one of the challenges, I think, in getting a decent sightline on our understanding. That's prompted you, Sam. Does that mean you found the Dr. Foster bit?
I've found the Dr. Foster bit. There is, in the case mix, the maternal age, it states OUH appears to have older mothers versus the national average, with 35, nearly 36% of mothers being 30 to 34, and 23% of mothers 35 to 39 against the national average of 19. It's sad that they think that that's old, but that's what's classed as older mothers.
I suspect when we dig down into that, some of that apparent extra age will be because of the specialist services that we offer, bring people to us who otherwise would birth more locally. So I think working out the implications of that is not always straightforward, and I think that's part of the challenge for us. Okay, I'm going to try and move things on. I just want to observe that, I mean, from Katrina's story, the complexity of care for these women came across. The number of different contacts and different types of contacts and people she engaged with is clearly apparent. So too is something that you very often hear from women whose experiences have not been so good, that they feel they knew things that staff didn't hear when they were asking about them. And I think it's really refreshing that Katrina tells us that actually that was picked up by the people that she spoke to. And when you look at the staff contributions to these perspectives, it's absolutely clear that they're aiming to respond to the particular women's needs and treat them as individuals. That is absolutely the core to compassionate excellence, I think, is that we're treating the women in front of us and we're not assuming things about them, and we're listening to them. Sam, that prompted a hand just as I was trying to move things on. I'll give you the last word and then we'll move on to the
no, I just really wanted to thank the board for their engagement. I've been asked twice this morning not to forget to feed back how the story was received. So it's really, really positive that, as Eileen says, there's learning from positive stories, and there's been such a rich conversation that I can feed back. I think it will really support the staff. Great. Well, will you pass on our thanks to them for the clear evidence of an excellent service for a group of people who are potentially quite vulnerable, but also thank the women as well for being happy to share their experiences with us, because that's key to us understanding the nature of the challenges that they and our staff are facing. Thank you. That takes us to our integrated performance report. I still think we've got some way to go on using this section of our agenda neatly, and a number of us having discussions about how we make sure we don't ask the same questions over and over again and think about thematically. But I'm absolutely sure that we do better in this section of the agenda
by moving straight to questions than asking the executive to guess what we might want to ask about and present that and use up our time on that basis. So I'm going to throw this open for questions and comments. Joy, is that a new hand or was that the previous one?
It's a new hand, actually.
Fantastic.
I'm getting a tiny bit more confident now.
We have Joy and Ash, and we'll be delighted to start with our newest appointees and colleagues. Joy.
So I just had a quick query on complaints. I wondered whether there was, in the narrative, it talked about complaints coming through because of obviously some concerns around COVID and what was currently happening to patients. And I just wondered whether that previously, what the complaint level was like. So prior to COVID, was it at that level, or was there a more of a drop? So it's just a kind of query. And the second question I had is in relation to safeguarding. So I know that we're below the compliance in terms of safeguarding, but we also are having an increased number of safeguarding concerns. And I'm wondering whether we are concerned about whether for me it was, is what we're seeing sufficient enough in terms of the training? Are there any concerns that we need to ensure that the training compliance is enables people to identify and to raise concerns, or is the training that we're currently happening it's seeing people through? In other words, I'm not sure that I asked that question as well as I wanted to, but for me, there was something about, how concerned do we need to be that people were not actually at the training compliance level with regard to the safeguarding. Thank you.
So before I let Sam pick that up, you've raised a very important general point, I think, which is our benchmarking, which typically looks at where we are against a previous year, may not be a particularly useful guide given the disruption of COVID. And so your question about how this relates to the pre-COVID position, I think, applies to lots of these metrics, and we'd take that away as a general issue about whether we need to just pull out, a set of benchmarks from our pre-COVID report so that we're just able to say, are we returning to a sort of normal state, inverted commas, and not just look at 12 months before, because that's a generic point that just doesn't come up in relation to this. But Sam, I think the points about safeguarding and complaints both probably sit best with you to respond to.
So Chair, shall I take that as an action that we do some comparators around themes just for our own assurance of where we're?
Yes, I think it's an action. We should make it more generic, though. And perhaps we all should ask ourselves, do we need, for say, the next 6 months, just to go back and have a benchmark from pre-COVID periods that just enables us to make an observation about whether the comparators would look different if we went back to pre-COVID. It may well be that they don't very often, and we should do that once and just ask ourselves whether, for the whole of the IPR really, there are benchmarks that would be useful just to have a reminder in a little box to say the figure in pre-COVID times would have been on average something like that. It won't apply to all of them, but it will apply to more than just the complaints one. So perhaps that's not just an action for you, Sam, it's an action for the colleagues.
Sure, I'll pick that up. And I think the context of COVID, Joy, has changed just the nuance of the nature of some of the complaints, particularly around communication. And as Megan mentioned previously, the visiting restrictions have really compounded that. Now, there are a number of hospitals still not even enabling the rule of one, which is our current rule. There's wider flexibility in that, obviously, for end-of-life carers, and other individual cases, but we are seeing this real difficulty, as we can all appreciate, around the ability to get communication via the ward teams and to communicate with individual patients. So you'll see a couple of areas of improvement where we're trying to improve different platforms where people can communicate, but I think that we need to go slightly further with that. And during COVID, we had particularly the medical students were fantastic in providing a family liaison service where they proactively telephoned relatives. Obviously, those teams are back in their day jobs now, and we're trying to look to put through some liaison team roles. Certainly, some of the intensive care units have already adopted this. We gave a Daisy Award actually last week to a nurse in neurointensive care whose role now is family liaison, and there were some fantastic themes around there. But I'll look a bit deeper, I think, Joy, to your question. In terms of safeguarding training, I think there's two elements to it. I think the first element, and we discussed this at executives yesterday, we're still cleaning up some of the data around our training compliance due to the introduction of a new learner management system. So I'm pretty confident that actually there are better training compliance scores because we've still got some paper documents to put in. I think the thing that concerns us the most is not so much the recognition and identification around the whole spectrum of safeguarding concerns, but it's actually the capacity out in the wider system to support individuals. So at the moment, the thing most concerning, the area most concerning for us is children and adolescents with mental health needs, and our work with our partners in both health and social care to support pathways against the national constraints that are. So I think I have a level of confidence around safeguarding knowledge, particularly in children's services where our paediatricians and our nursing staff are very well trained and acutely picking up. It's not the lack of partnership working, but it's the national capacity issues we have around CAM services that are provoking the most anxiety amongst us. On the adult side, likewise, but to a lesser extent.
Thank you. I suppose there's a sort of risk assessment element to that stuff on safeguarding, isn't it? If the people who are most likely to need to have this have the level of knowledge we need, that's better than us training up people to meet the target, but actually they're not the ones that we need the most confidence in. So I think it's good to hear you give us that confidence that they've got the knowledge.
And these training figures are our mandatory training, so it's not that we're not trained. It may well be that we haven't had our annual update. So our base knowledge on the Care Acts, and the areas of knowledge that we require are embedded from years and years of training. This is a reflection of our annual updates.
Thanks, Sam. I mean, Joy, I retain a niggle on safeguarding that we don't have a very good way of understanding the impact of the pandemic. So there may be safeguarding issues which are hidden because of less contact with services from people, and it's really hard to know whether the numbers that we look at tell us whether we're doing well or not, because we don't really understand the nature of change. It's very plausible that the pandemic has increased the vulnerability of significant numbers of people, but also reduced the opportunity of people to spot that and support it. So I think we should keep plugging away at how well we understand what's going on in this area, because it's really uncertain what the impact of the pandemic has been. Thank you. I'm going to go to Ash next.
Thank you, Jonathan. Having said don't be repetitive, I'm about to be.
I'm going to ask about medicines reconciliation.
Yes.
If you're not, I'm going to ask about it.
Because it's not just that it's still not good, it's actually deteriorated quite markedly, and I'm slightly worried as to why. I know Megan and I had a conversation with the chief pharmacist as well, but I'm slightly concerned that I'm seeing data which is going the wrong way rather than the right way in any shape or form. And I suppose the other question that comes alongside that is that if our reconciliation is that poor, potentially, does that leave us at risk that patients are not taking the correct meds when they are first starting until we've got that reconciliation sorted? Because I know how poor patients are at remembering their own medicines.
So are you looking at the metrics table, page 40, which shows a slip to 50.9 for July? Good. That's where I picked it up was from. Ash. Megan, is that for you?
Yeah, I'll take this, Chair. So
well, you could give it to Elaine if you were really mean, because she's preparing for this.
But I'm not mean. So Ash, thank you. And yes, we did have a discussion with Boo, who's our chief pharmacist. So first thing to say is the reflection in this figure of 50.9% is again mainly related to the weekend cover. So during the week, we are very high, almost in the 90%, but at the weekends, we do not well because there's a resource implication, and that's staffing. We are struggling to maintain our staffing resource over the weekend, particularly at this time because they have been redeployed to doing other things, which is COVID-related activity. And now we are about to start the neutralizing monoclonal antibodies service as well. So this is a reflection of this pressure on the service at the moment. I have to say that the business case, which has now been rectified for a third time, I think, Sarah and Jason will know more, is on its way to business planning group. And that's the only update I can give. The assurance I can provide is that the medicine safety group, which has been set up, which reports into the clinical, into the patient safety and effectiveness group, which then reports into clinical governance committee, looks systematically at medication errors, of which omissions is a bigger part, as you know, and there aren't any moderate or greater harm incidents that have been reported to me as a result of drug omission at the moment.
Can I just come back slightly on that? I
Yes.
suppose my concern is that you say that, so this is people being redeployed because of COVID, but COVID's now been going on for a period of time, so it seems it should be less of an issue at that point. And the implication therefore
Maybe
is that you're
it's more of
seeing
an issue because if this is becoming business as usual, then we can't rely on going back to where we were in the foreseeable future.
Sorry, the other point on that though is that the suggestion therefore is that you're seeing higher admissions at the weekend than you have been, because if that number is reflective of weekend activity particularly, then the decline would indicate that you're seeing higher admissions at the weekend. I just wanted to check if that was the case.
So just to answer that together, what we have is pharmacy staff who are having to do other work as opposed to the work that they were doing, which is MedRecon at the weekends. As it is, we are short-staffed at the weekends for pharmacists doing MedRecon, and then we've had to take that pool of staff and redistribute them across other areas or services, which has meant that the number of people working on the wards clinically for medicines reconciliation weekend has dropped further, rather than the number of patients being higher. What we do is our chief pharmacist reports regularly on this, and unfortunately at the moment he's needed to prioritize his resource. That's what the issue is. So
Megha, I'm not a mathematician, but if you have 90% for 5 days of the week and the average is there can't be anything doing at the weekend. I think there's a couple of things that should follow from this discussion, Megan, which perhaps we could ask there to be an observation on in the IPR, when we bring to the Integrated Assurance Committee the next discussion of this. I think we should understand what the difference is between weekend and weekday, because it's clear that average obscures the problem from us. It's not a problem across 7 days. It's a particular problem that's focused, and I think we should therefore understand what the difference looks like. I think we need to link it explicitly on our record with the points you make about the harm assessment. So it's one thing to know that we're not doing the reconciliations. It gives us assurance if we're checking whether that has led to harm, and we have a process for doing that, and we can see whether this is a process that we can assure ourselves is not where we want to be, but we're checking whether it actually causes harm to patients. And then just an understanding of the likely timescale on the business case. So if we could ask for IAC to have a briefing on that when it next receives the IPC, I think we can then work out, Ash, whether we need to ask for more or whether those are addressing the questions that are there. Thank you. Ash, did you have any other questions, or does that do for today? Thank you. So Claire, you were next, and it'll be Sarah Horden after Claire.
Thank you, Jonathan. I guess would like to ask about the statutory Statman training and appraisal, and in particular the My Learning Hub, which we spoke about last meeting. I mean, I suppose I have an increasing feeling of unease around this, not only because, you know, both of those things are sort of CQC indicators, but also because they're just so important. And I think we agreed last time that we're sort of lacking line of sight because we don't have the data, but the fact that My Learning Hub isn't really up and running is also affecting the actual numbers of appraisals done and statutory mandatory training completed. So Terry, I know that, you know, you're doing everything you can to try and get this right, but could you give us a sense of where we are and when we're likely to be out of the woods, and also sort of how we're going to help people catch up if things have fallen behind as a result of these problems? That was my first question. Do you want me to pause there, Jonathan, or should I ask my second as well?
I think you should pause there and get an answer to that before you move on.
Thanks, Claire. Yeah, it's a really important point, and something that actually, as an executive team, we're concerned about as well. So for month 4, we couldn't report. We now are in a position where we actually know what our appraisal and our core skills training is. So at the end of August, it was 84%, which is actually quite close to our target of 85%. So we're in a position now where we'll be able to report going forward. Our appraisal position, however, is significantly worse, and that's at 54%. What we have been encouraging the organisation and divisions to do is to do paper versions of the appraisal and upload those. There's a facility to do that, and so where the HR business partners and divisions are working across the organisation to ensure that they are uploaded, so that actually we can actually deal with it now. So we're in a position now where the appraisal system is working, the upload is working. There may be some issues in terms of just making sure that everybody understands how it works. And we've got the HR BPs working with the divisions. We've got the cultural leadership team working also with the HR BPs to make sure that that's the case. We're also dealing with the backlog of issues that have occurred as well. So we are able to report now. So I don't know if that allays some of your concerns.
Yeah, thanks, Terry. That's very reassuring. Are there still issues with the hub, or do you think we're now sort of it's working properly?
Yeah, so I think it's working properly. I think the outstanding issues are making sure that people know how to use it properly, because we're still getting people pointing out, I can't see my team. Oh, it hasn't been uploaded. All these things such as IT and governance issues, such as, well, can my PA upload my appraisals for me, etc., etc. And so there's things like that which we need to work through. But the system as it is, I've utilised it myself for my team, and I've tested it myself. But there is a backlog of issues that do need to be addressed.
Well,
so
congratulations.
just before I go on to question 2, Claire, so are you saying, Terry, that we've reason to believe that the hub is now working as we hope it does, and the training figures give us assurance on that, and you hope in due course that will come through for the appraisals as well, but you're a bit less confident on that trajectory than you have been on the training?
Yeah, the appraisal piece, I think some people may have not had confidence, so may not have even done the paper version. So it's about getting the system, making sure that everybody understands that the system works properly, and so they don't use the fact that actually, there were problems with it in the past to not do an appraisal.
Okay, thank you. So I don't think we should let go of our worries about appraisal on the basis of that, as you're saying.
No, not at all.
Claire, question 2.
Yeah, quickly then, for Jason, really, moving on to the finance section, there's a comment under COVID-19 that we're underspent, and I understand that, and that we've rightly sort of had to redeploy those funds elsewhere, but that there's a risk associated with that should the rules change. And I just sort of wanted to understand both how we're managing that risk and indeed whether we're having the right conversations sort of at ICS level and at regional level to make sure that we're in a good place on it should things alter.
Thank you, Claire. Well, as the paper says, both in that section and a little bit below on the sort of note on the forecast, there's a wide range of outcomes for the level of funding the trust will receive in the second half of the year, and it's not clearer to me after yesterday's announcements. There is a national CFO's briefing on Thursday that went in the diary, funnily enough, yesterday evening, so I may be able to brief next week. So on the one hand, there is some limited contingency planning being done for what discretionary expenditure we could not continue with in the second half of the year in the worst outcomes. The thing I would caveat is as I think I said to the board, or what I said at IAC, sorry, we're just coming towards the end of the third successive 6-month planning period since the start of the pandemic, financial planning period, at which the details of future funding arrangements are made available in the sort of week or two before the start of the next 6-month period. And in the previous 3 6-month periods, the funding has generally actually been, generous and sufficient to combat the global pandemic. So what I don't want colleagues to do is start preemptive belt tightening on the basis that we have to live with the lower end of those scenarios to the detriment of either patient care or our strategic objectives. And the range of outcomes is really quite wide. And to be honest, regional ICS colleagues are, and then unless they received a brief, for example, last night, are no better informed than we are, as it were, about where we're going to land on those scales. It's a well discussed issue at actually we've had exec conversations about it, TME conversations, ICS and regional conversations about the reliance of most providers on either elements of ERF or COVID underspends to fund core operations. And just the one thing I'd say, and there's a little element of a sort of NHS England accounting requirements here, we're only allowed to classify certain costs against COVID, and they tend to be the incremental costs. What we're not allowed to do is to record as COVID costs the redeployed staff. And so there is there's a slightly sort of fictional element to this in that we're doing some estimates of this internally. There are some staff redeployed internally from their day job where we count the costs of them in, as it were, the underlying position, but the income is effectively they're being funded by COVID costs, and that makes things a little tricky. Our true COVID costs are more than what NHS England allows us to report to them.
Understood, Jason. I just wanted to come back, and the second part of the question was really about making sure there were no surprises outside the organisation in terms of where we might land, and making sure we were having the right conversations on that. And could you reassure me on that?
I can reassure you that our cost base, along with that of the rest of the ICS, is well understood at an ICS and well communicated at a regional ICS level.
Okay, thank you. That takes me to Sarah Horden.
Thank you.
Paula will be after Sarah.
Claire's kind of asked half of my question. So I think, Jason, just in principle around the finances, though, I know you're working in some of the feedback through the finance governance review, but I think part of this is about how we make the executive summary more powerful. And perhaps there are some graphs creeping in the finance section, which I think are quite useful, but actually moving forwards, there's a lot of words. And actually, I think I'd quite like to understand. So Claire's picked up one of the key risks around COVID, but I think there's an ERF risk in there as well. And I think somehow if you could and your team could think about how we can maybe use some bridges so we can see really what the key movements are in something very simple. That I would really appreciate that. I think it would allow us potentially to ask better questions and focus on the key issues. And in light of that, can you you've talked about the COVID money, but I think, can you also perhaps talk a little bit about the ERF funding and the risks on that? And I wonder whether last year we had a risk table that you did as we came into the year end, which is what were the key movements and what were the probability of them happening. And I wonder if we should be in that kind of territory again with COVID and ERF.
Thanks, Sarah. Yeah, so actually, you may recall that for the first half of the year, which is the only period we have actually any data on at the moment, for the forecast for the first half of the year, that table was appended to the IAC report. So we have restarted it. And although actually we didn't spend much time at IAC on that paper, actually IAC saw that table in, it was August, wasn't it? I think in early August. We'll bring that back. It's in terms of ERF, we have no information. I mean, just to be clear, we're sitting here on the 8th of September, and we have zero information about any aspects of the funding regime on the 1st of October. And so when it's not possible to really say much more than the risk, as it were, the uncertainty on ERF ranges from there will be zero up to there will be a regime that is more generous than what we have at the moment. And the experience of the last few months, I think, actually bears out that wide range of scenarios. So board members will know that the ERF regime for the first half of this year was published on the 26th of March. And under that published regime, we earned about £26 million of ERF in Q1. Now, the ERF regime was always tapering to be a bit tougher month by month, and then it was going to stabilise for Q2. And then I think it was July, the regime was changed for Q2. Actually, the effect of that change is probably going to cost OUH or the ICS, but the equivalent of £4 million of ERF a month that OUH would have generated in July, August and September. So, I mean, if risk is uncertainty, there's a very high degree of uncertainty about ERF because we didn't know about it on the 25th of March. We thought we had a regime for 6 months. 3.5 months into that 6 months, the rules were changed. And 3 weeks before the start of the next period, I have zero information about ERF in October. So there's a very wide range of outcomes on ERF, say for the second half of the year, ranging from perhaps £0 up to 30 or 40 million pounds. And that's really rather difficult to plan for because it's not a narrow band of uncertainty, it's a very wide band of uncertainty.
For those who may not remember, ERF is the Elective Recovery Fund. So those watching us on YouTube can pick that up at this stage. This is a real challenge, isn't it? Sarah, what should we do? In the longer term, I'm inclined to say, if we can't easily plan for the money that's flowing around the system, we can concentrate on our own productivity and governance and at least be confident that we are preparing ourselves for whatever does emerge. But there's a real challenge in terms of our risks around year-end position, and it's not very clear how we can plan for that. Do we ask for Jason to drop us a briefing note after the meeting on Thursday when hopefully the chief finance officers are given a bit more understanding of how the announcements made during the week are impacting, or is there more that we could do at this stage, Sarah?
So I think we almost need to separate the two issues. So there's one, absolutely, Jason doesn't have a crystal ball. We've all got to live and deal with what comes out as and when it's available. And I'm not asking Jason to second guess this. I think what I'm asking for is a bit more clarity. There's a lot of words here, but a bit more succinct clarity in how we're treating this in the account. So I think, Jason, you've got a provision in here effectively. So you're trying to manage our risk exposure. And I think being able to understand what the scale of the problem could be and how much contingency you're handling at the moment in order to try and manage that risk through to the year end would be really helpful. Totally accepting you're working in a world where we don't know what's going on.
Yeah, I mean, what we have at the moment is set out on page think, I'm not sure it's 95 of the whole pack or 90, can't be 95 of the, I hope it's not page 95 of the integrated performance report. I'm on diligence, so maybe it is page 95 of the IPR, where we're holding 9.3 at the end of month 4. We were holding 9.3 million pounds of ERF in reserve, of which under the system agreement on ERF, notionally 3.6 is for us and 5.7 million is for the rest of the ICS.
I'm afraid, Jason, it is 95 of the IPR. It's 143 of the whole pack.
And I think that really kind of reinforces my point about the thinking around how we distill the key risks in the finances and the key reporting in the finances, so that the exec summary is really clear about where the numbers sit, what the bridge is to plan, and what those key risks are, rather than a very narrative style about where we are on each line item.
So I think, Jason, we need some way of representing in the dashboard. At the moment, it could be between naught and. Hopefully after Thursday, it won't be naught and, it'll be a little narrower than that. But we do need to understand something like a worst case, best case, reasonable expectation sort of picture, and what are the plans for managing the year-end position in those contexts. Is that the sort of thing, Sarah, you're after?
Yeah. Okay. Yeah, that would be great.
So Jason, perhaps after Thursday,
I have to say I don't think there'll be much clarity on Thursday. I can write a note on Monday, but I think it will say
whether that's a realistic expectation and when we might be able to think about it. But I think that's where we need to move ourselves to.
The only thing I'll say, I cannot promise to bring clarity to a situation which, through no fault of the trust, I think is inherently very unclear. But I will try to make the lack of clarity a bit clearer.
So I think where we are is we all accept that there's the risk that goes with uncertainty. We need to try and understand what that might mean for us in terms of choices we need to take, risks we need to give you cover for, because if we're running risks as an organisation, those shouldn't be sitting with you personally. We need to understand.
No, they're not, and I think that's fine. The executive fairly well briefed, had taken Bruno through a lot of the detail on this. We simply don't have the information to round the scenarios down to a range that is useful at the moment.
Okay, well, we'll work on that, and Sarah will ask that question until she's got a better graph that's there, and I'll encourage her to do that. Paula.
Apologies, I need to get off mute. So a couple of questions, Jonathan, if I might. So the first one, we've asked over the last couple of months, or we've been monitoring the reduction in the 4-hour wait statistic. In fact, I think you led on that questioning last time, and we talked quite a lot about some of the actions that were being taken. As we roll on to this set of reports, the trend continues in a downward direction, and then it couples with an increase in our length of stay, which we all know is intrinsically linked with the two things work very much hand in hand. And I think we all understand the difficulty around length of stay and the system working to make sure we get that back. But looking at the way the trends have gone now, I just feel we need to ask ourselves, or ask the team, do they feel that the actions that they've talked about over the last few months are really going to bear some fruit? Because that's not the way the trend is showing us at the moment. We've gone down again. And I know the AAU was closed, I think, at one point during the month, but I do think we need to understand whether what we're being told about the actions is there any confidence that it's going to shift these trends?
So I guess what lies behind that is, do we need to hold our nerve and continue them because the team has confidence that the trends will shift, or do we need to be thinking about a different approach if they don't have that confidence?
Absolutely.
Sarah, I think your hand's gone up to answer that question.
So I think if I make a start, Chair, and then perhaps pass on to Sam about looking at what we're doing across the system as well. So you're quite right, Paula, that our performance has deteriorated over the last few weeks and months. What we have done is we looked to put in additional staff for the times that we've said we'd do, and that's been difficult because where we put staff in, and that was on a voluntary basis, we didn't get the staff that we wanted over that period of time. What we have seen is a significant increase in those attendances, and also the number of admissions has gone up. So, and certainly over the last week or so, even last night, we were seeing over 100 patients in ED, and that was at early on, even in the afternoon. So the attendances are significant. What we have seen, as you quite rightly point out, our length of stay has also increased. So we've got about 3 wards full of patients that are not are fit for discharge, and we need to move those patients on to the right destination. But often those are complex discharges, and Sam will perhaps come on to that. So we are meeting weekly with the MRC and ED team. We're putting in a cross-divisional improvement group that Lisa's and I'm going to lead with the team. So we're refreshing our professional internal standards to support all of our clinicians in supporting ED, and looking at how we can extend some of the AAU, the ambulatory SDEC space, so that patients can be seen earlier in that morning and also late into the evening. So we are refreshing what we've done before. The issue has been the workforce that we initially put in has not we didn't get to all the workforce that required, and as leave has subsided, and we've got more recruitment of staff, that's easing a bit, but we need to refresh our improvement actions, because they're not managing the actual numbers coming through the door.
Thanks so much.
Shall I pass on to Sam?
Thanks, Sarah. So as Sarah said, there's a range of internal improvements that are in train. If I focus more on the flow out of the hospital, where we are today, 16% of our patients across our 4 sites are over 21 days length of stay. Now, a number of those are on medical pathways, so there is a requirement for them to have an extended length of stay, but 26% of those patients are medically fit for discharge, which equates to circa 3 wards full of patients whose care should be provided outside of the hospital. The big outflow risk that we have at the moment is long waits for domiciliary care, which is impacting on flow through the heart service, who provide reablement. So there's a big focus on capacity and demand. This is further compounded over some timing around the transition of the county council as we end our contracts for the heart service, and the new providers are starting to transition in. So we're working closely with partners to assess the risks and try and mitigate that transition across to the new partners who will be providing reablement across the county. Working very closely, Jason and I and Sarah, with Oxford Health under the Ageing Well umbrella, which is focused on urgent community response, so response time within 2 hours to prevent patients coming into hospital or to enable them to exit the hospital. And we're working on a business case with an option to remain within financial envelope, or indeed with a cost pressure given the current demand. We're also scoping at the moment, and part of that business case will also be expanding end of life provision, and actually some quite exciting potential strategic developments to close the gap across the whole county, and work with a number of partners so that we have one offer for Oxfordshire. So there's a lot of work going on in the background, but we're absolutely crippled by the long waits out of the hospital at the moment.
So, Jonathan, can I come back on that? Because
I'm going to invite you to, because I'm not sure how that answers your question, if you like. It shows it's a good question, and it shows how difficult it is, but I'm not sure whether it quite addresses your, tells us whether we should keep on with this or we need to think differently. So back to you.
I'm getting a bit of a sense of deja vu, and it's not that I don't completely understand and have empathy for exactly what Sarah and Sam have said, but I tried to phrase my question to elicit some confidence around whether or not there was a sense that what we were doing would change the trend. I don't really get that. That's actually not a criticism. I think it might be a fact of the reality, actually, and it just how hard it is. But if we turn the clock back a little while, this was our core focus at one point, a couple of years ago, and we had really got to a much better place. And this has a real sense of, I worry that I'll turn over the page next month and this trend is going to be even worse. And nothing I've heard changes that. And that's not me criticising the team at all. I just sense that we don't have that feeling of, okay, we have a plan, and I know it has to be a system plan. I completely understand that, because the end part of that is so crucial, the length of stay. But I don't think I've got. I think we have to ask ourselves, are we just going to wait and turn the page and see, or is there something? Do we need to escalate this in some way? And I use that word in its most general sense because the team here are as good as it gets, really.
So, Paula, I think I'm inclined to think the outcome of this discussion is that we should ask IAC to have a look at this at the next meeting, because I think we're saying we know a lot of work is going on, but we're not confident that that can give us assurance on where it's going to lead to. And I'll suggest that's what we should do, and I'll give Sarah and Sam a chance to just make a final observations on that. Sarah?
So there's a couple of points perhaps I didn't mention as well. So I think we are reviewing, and we've just completed a number of different audits in the department, actually, Paula. So looking at all the areas that we are not delivering on, whether it's the time that patients come into the ambulance queues, the offloading of ambulances, the handover to the ED team, and how long patients wait. So we're just completing that just to see what other areas that we have missed or we have changed that we need to review. So we're just going to review those audits. I just also wanted to say, if you actually looked at the South East Regional dashboard, almost every single trust is in the same position. Last night there were a significant number of ambulances waiting to be picking up patients across Oxfordshire. So I think there's 40 calls outstanding for scabs. That's what I was told at 11 o'clock last night. So it's significant pressure on the systems. So Oxfordshire is one of those, but we need to make sure at all times our patients are safe and our staff are safe. So that's what we're absolutely focused on. And I think helping to, if we brought the improvement plan to our IAC and perhaps have a more rounded discussion with the MRC team, that might be helpful for at the IAC.
Thanks, Sam, and then Megan, and then I've got a couple of things I want to raise, and then I'm going to try and give you a break.
I think, Chair, just to comment on escalation, I think I described last time a level of confidence around escalation at place level, and I've just completed the A&E Delivery Board exception report, which will go to system chief executives. I suspect Megan will be taking that unless that's tabled for when Bruno's back, but that's where James Kent and the Adult Social Care and Oxford Health chief executives will review performance as a system. Equally, we've been asked to attend HOSC to give a narrative around current position and plans for winter. Also, there's escalation out of area. So we've currently got 17 patients out of area delays, predominantly in Northamptonshire, and that's escalated up to chief executive level of Northamptonshire County Council.
It sounds as, Sam, if the substance of that escalated chief execs could be worked through with IAC, we'd get a sense of the sort of answers to Paula's questions. Megan, then I'm going to ask my couple of questions, and then I'm going to try and get us to a refreshment break. Megan.
Thank you, Chair. I was just simply going to say that actually there are internal actions and system actions that we need to follow through, and that we can set out very clearly with a trajectory for improvement for the IAC paper in October. And of course, always focusing on patient safety to provide that assurance.
Thanks so much, Megan. So I think the action from this is that it's going to go to IAC, and we've got a number of ideas here about things that could help inform that without needing lots of extra work, because it's pulling stuff together that's being done elsewhere. If I could just pick up a few things around recruitment and retention of staff absence. Terry, I'm noting that if we look at the staff absence rates, there seems to be a sort of COVID plateau, and so on page 75, you can see that there's it looks as though there might be a new normal level of staff absence, and in the following page, you've noted that of the absences, BME staff account for about a quarter. And we've asked previously about sort of long-term absence and people who need support in getting back to work. And I wondered whether that was what was showing here, and you could just update us on where you think we are in terms of the support that we're giving for those people who have essentially quite intractable reasons for being absent when the COVID epidemic is about, and how we're supporting those people.
Yeah, so in relation to, thanks, Jonathan, in relation to long COVID, we only have a small number of people who are off with long.
It's not so much long COVID as people whose reasons for being absent are related to COVID and are enduring. So perhaps I shouldn't have used those two words immediately next to each other.
Yeah, no. So I was going to go on to the other longer term people, but for long COVID, we only have about 19 people who are off with that. Some of the longer term sickness absence, and what you'll see is the bulk of some of our long-term sickness and our sickness overall, the highest percentages is due to anxiety and mental health reasons, with anxiety being a subset of that. The actions that we're taking to address that are one, the R3P program, which is also looking at how we support teams as well that are suffering with the effects of COVID. We're also launching, and we've launched this week, wellbeing conversations, which will not only happen with your current staff to make sure that those people don't go off, but the intention is for that to happen with people who are on long-term sickness as well. We're also looking at the overall sickness absence process as well, and we're monitoring those people who have been off and who have the longest sickness. So we've looked at the top 20 in each division, and one of our initiatives is to have a regular meeting with occupational health, case conferences with occupational health and the relevant HR business partnering team, which probably would feel as a standard mechanism, but we haven't done that before here. So that way we can actually get through some of the issues. We can understand more thoroughly what those issues are, where individuals are not releasing information, which will hinder us taking cases forward. We can get an agreement with occupational health about how to move that forward. So there are a number of initiatives, some big ones under Growing Stronger Together, like R3P, some specific one around the policy, and also about how we work more effectively with occupational health.
Thanks so much, Terry. That's really helpful to assurance about the range of things we're doing there and the way it's tailored to solving those problems. It's clearly a small group of people, but who need quite a lot of support. So that gives me a lot of assurance. I'd like to end the IPR section just to ask a question about recruitment in adult critical care. I don't know if this would be Sam wants to pick up, but one of our challenges on understanding our vacancy rate is, of course, sometimes we are looking to recruit large groups of people in the same time. And I clicked on the link and have seen the very nice presentation of the opportunities to come and work in New Critical Care Centre. I just wondered what our confidence is that we'll be able to recruit the people, both the number and the quality of people that we want for that. And wonder, Sam, whether you wanted to just update us on whether you think these things are going well.
Thanks, Chair. Yeah, Jason and I reviewed this with the team yesterday, and they had a successful virtual recruitment event, which is, I think there's not a problem recruiting fairly junior staff. It's the band 6 level of staff that we're really focusing on now. So Terry's team's supporting us in really focusing that without destabilising Bob is our balance. So combination of international recruitment, internal development, and wider catchment.
Thank you very much. Jason, as Sam said what you were going to say, your hand flicked up momentarily.
Only to say, Chair, that board members will remember we haven't actually, the recruitment you can see online at the moment is actually only the first tranche of the amount of recruitment that would be needed to fully open the incremental, completely incremental capacity. And we're still both negotiating with the region and ICS further funding, and we'll come back to the board for an authority for further recruitment beyond what you can see when we get that funding. But actually, it's a timely comment, because what you can see online at the moment is actually only a portion of the recruitment we would probably like to do if the funding is secured.
Good. Well, that's a cue for us having a coffee break, on the basis that the future is improving further and expanding services in that area. But as you've said, Jason, there's more the board will need to know about that and to support in due course. But we're a little bit behind time. We should take a 10-minute break or so now and start again at 2:45. And at that point, we'll be picking up the expression of interest for securing money to invest in Banbury at the Horton General Hospital. So see everybody again at 10:45.